Hello guys, and welcome to my YouTube channel. My name is Dr. Peter, and today is a more academic like YouTube video. I had a presentation to make at work, and I was supposed to discuss about how to care for cancer patients. What are the considerations that people have when you do palliative care? So I went online to do some research, and I found scattered materials. I couldn't really find a YouTube video that was really that addressed what I wanted to do for my presentation. So I decided to do the research, put together some slides, and then after my presentation I'm like, okay, why don't I share it with my community of medical students and young doctors and medical professionals here on YouTube, so that you can see the considerations when it comes to palliative care. By the way, if you're new on my YouTube channel, welcome. I'm glad to have you. It's been a while, it's been months since I put out any video on YouTube, but I'm glad that you are joining us today. So today, straight up to the point, considerations in palliative care. As you know, the world is changing. Disease epidemiology is changing. Even in the developing world, there is more, the burden of non-communicable diseases is rising. So things like heart failures, chronic kidney disease, cancers, the risks are rising for people even in the developing world. Previously, it used to be communicable diseases, infections. And those are still the leading causes of death in the developing world. However, we're beginning to see that chronic cases are beginning to become quite much in the developing world. So today I want to talk about considerations in palliative care of cancer patients. I'm going to be using a slide here, and I'm going to be sharing it on the screen with you. So just follow with this presentation. I think I'll drop a link to a Google Drive where you can actually download the presentation, just so that you can also see and learn from it as well. Now I'll use the following outline. We introduce the topic, talk about cancer burdens, we look at the goals in palliative care, we'll talk about symptomatic management. That's where we're going to actually stay in this discussion. We'll talk about pain management. Someone said pain is not just, pain is very important to clinicians. In fact, someone talked about pain being the 5th vital signs. You guys, vital signs, the vital signs: pulse rate, respiratory rate, temperature, and as well as blood pressure. But pain is considered as the 5th, vital sign. We're going to look at pain management in palliative care. Then we'll talk about family and care giver burden, which is like underrated, but which is a very important part of chronic care or palliative care. We'll look at the challenges in palliative care, and then we'll wrap up the discussion all together. Palliative care, this is the WHO definition for palliative care. Palliative care is an approach that improves the quality of life of patients, both adults and children, and their families who are facing problems associated with life-threatening illnesses. It provides and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. This is WHO definition for palliative care from 2020 rather. Now, this is the old approach. The old approach to palliative care was, surgeons, clinicians, oncologists, they manage the patient actively, aggressively. And then when you now discover that, okay, the patient has multiple metastases, then there's just a sharp, abrupt transition from palliative care to, from active management, from curative treatment to palliative care. But now we know, modern clinicians, what we advocate today is actually a continuum of care from curative treatment to palliative treatment using this model. So instead of waiting, and managing the patient for curative care and then abruptly transiting to palliative care, at the onset of the disease, at the diagnosis of the disease, the patient is cancelled, and then palliative care is instituted. And I can also tell you that palliative care is instituted via counseling, which is actually like a pivotal keystone in palliative care. Now, palliative care is multidisciplinary. It commences at the diagnosis and ends at death and bereavement. So at death and bereavement, the focus of palliative care is on the quality of life, like 5-star on the quality of life of the patient, comfort needs, and then other needs that the patients might have. Patients who need palliative care are not restricted to cancer patients. Patients who have chronic kidney disease that do not meet the criteria for transplant, patients with chronic heart failure, patients with dementia, and a myriad of other conditions actually require palliative care. So expand your mind, broader than just cancers. Now, this is the global cancer burden. I want you to look closely at this graph, at this figure, and you see that I'm making this presentation for Nigeria, West Africa, Sub-Saharan Africa. If you look down there, the part of the slide, that the part of the figure that is in turquoise blue, you see that 5.8% of new cancer cases are diagnosed in Africa, and which makes a huge part of the developing world. Now, if you look down there, you see that the International Agency for Research on Cancer has said that 1 in 5 men and 1 in 6 men worldwide will develop cancer over the course of their lifetime. And this translates to 1 in 8 men who will die from cancer, and then 1 in 11 women who will die from cancer. It's important to know that it's an important cause of death globally. So this is an important topic for you to know, because once in your profession, in your practice, in your clinical practice, you are eventually going to have to manage patients who you're going to actually institute palliative care in a patient. So this is an important topic you want to think about. Now, cancer is the leading cause of death worldwide, accounting for nearly 10 million deaths in 2020 globally. So this is an important thing you want to check out. Now, the goals of palliative care, as I said earlier, the goals of palliative care, we focus on the patient, not the disease. Sir Robert Hutchinson mentioned to this, alluded to this in his epitaph, in his famous epitaph. We're not treating cases, we're treating patients. We're not treating diseases, we're treating patients. So at all times, keep that in mind. We approach the patient holistically: physical, psychosocial, spiritual, ethical, legal. We consider all this in palliative care. And then, of course, an effective, harmonious communication with all the members of the health team will be important. The most important part of palliative care is that we focus on the quality of life of our patients. Now, if you look at this graph, you see that in all medical interventions, there are those that are purely general, purely therapeutic. It doesn't have to be palliative or not. There are some that cut in between palliative care and general care, and then there are some that are purely palliative. Now, let's look at the ones that are purely palliative. By the time we start looking at emotional, spiritual, and psychosocial support, control of pain, control of the symptoms of the disease, of those end cases of cancers, then we're talking about palliative care. Now, transfusion can be both for palliative care as well as general care. Infection control and infection treatment, hypercalcemia, tube feeding, those are general. Those can, they are variable. They can be general, they can be palliative. They can as well also be, general non-palliative care. But when it comes to CPR, ventilation, dialysis, those are like general, palliative. Although dialysis is something that cuts between palliative care and general care. As you say, if you are new on this channel, please like this video and subscribe to this video. You're obviously enjoying it, and then share the links to other clinicians and young students and doctors who might be interested in topics like this as well. Now, the most common symptoms seen in patients with advanced diseases are pain. In 86%, 84% of patients who will need palliative care complain of pain. So this is probably the most important part. Loss of appetite, nausea, vomiting, sleeplessness, dyspnea, constipation, depression, loss of bladder control, incontinence. These are the highlights of the problems, and these are the things we're going to pay emphasis in this discussion. Now, symptomatic management. Now let's really discuss how to manage these cases, because these are not things that you probably not find them all together in one place. So these are subtle things, and they are very important to the clinician, because by the time you're managing the patient by the bedside, you see that these problems actually are more pressing to the patient than even the diagnosis that you've established. These are the day-to-day activities of the patient that affect the quality of life of the patient. Now, for loss of appetite, oral hygiene. If you do oral toileting for patient might have plaques, dental issues, drugs that you have been given. Patients on tube feeding, for example, over a long period of time, you need to do some level of oral toileting for this patient so that they can appreciate the taste of food, and then maybe this will revive their appetite. You want to treat oral sores. Patients with angular stomatitis, patients have not been eating fruits, vitamins have been poured, patients have developed chelosis and things like that. You want to treat those sores, or at least give them something to relieve those pain and those discomfort, so that they can actually have appetite to eat. You want to treat local infections, stomatitis, pharyngitis, tonsillitis. Those patients with cancers can still have those kind of symptoms, and if you treat them, if you address them, it will improve their appetite. If the appetite loss is so poor, you can want to consult a dietitian. Also, if the patient is having constipation, of course they will have poor appetite, because that discomfort will make them not want to eat again. So you want to address constipation, and then maybe their appetite will improve. Don't forget that anorexia is actually intrinsic to the dying process. So by the time you start seeing this, it is not strange. It is component of the disease. Now, for nausea and vomiting, You want to modify the diet. It's so important that you address loss of appetite, but for nausea and vomiting, you want to modify the diet. We found out that bland, soft food is more tolerable to patients who need palliative care. You want to adjust the timing of the food. Maybe give the patient the food the times they are most comfortable, the times they are most happy, and then they may be able to tolerate and then not vomit this food. And of course, in worst cases, you can do antiemetic drugs. You can start with simple drugs. You can start with first-line agents like metoclopramide and all that. But when the time comes and the patient is already on chemotherapy, maybe you want to add, drugs like lansitron and the likes that would actually reduce the nausea and vomiting the patient will be having from the chemo. In addition, aromatherapy is also found to reduce nausea and vomiting. The word might be, all sterile, smelling of antiseptic and all that. So by the time maybe you burn lavender or peppermint in the room, it might, improve the patient's tolerance to food and reduce nausea and vomiting. Sleeplessness, environmental control. If the room is too cold, make it hot. If the room is too cold, make it warm. If the room is too warm, make it cool. You want to adjust the beddings of the patient. You want to make sure the patient has light out, what we call sleep hygiene. What that means is if the patient is on the bed, you must make sure that every other light is out, the room is controlled, the sound is controlled, there's no noise, there's no mosquitoes and insects that will disturb the patient. These things will improve, sleep of the patient. During the day, you want to engage the patient in passive exercise, not heavy exercise, but passive exercise. That exhaustion during the day from exercise will help the patient to fall asleep when the time comes to sleep. And then there are also medications that you want to introduce to help with sleep. But don't forget, try the non-medical approach first before you start loading the patient with medication. At this point, your patient is almost a pharmacy. You are given, a gamut of medications already. So at this point, you want to try to not increase the pill burden of the patient as well. For dyspnea, it is found that, the standard Fowler's position, nursing the patient at between 30 to 45 degrees head up, is the most comfortable position for the cardiorespiratory function. So at this point, fluids gravitate downward, so the patient can have more ventilation in the upper part of the lungs, and then this will improve the dyspnea. So position the patient. If the patient is having secretions, oral or nasal and oral secretion, you want to do gentle suctioning. If dyspnea is too bad, you want to comment on oxygen therapy to reduce the work of breathing and to improve the patient's saturation generally. Of course, control the environment again. Hot weather has been known to cause dyspnea even in healthy people. So you want to control the environment in this particular case. Now, of course, you want to regulate fluids. Fluid overload will cause congestion in the lungs and will reduce ventilation perfusion ratio, and the patient will be dyspneic. We've also found out that opioids and anxiolytics will help the patient. This patient might be emotionally distressed and all that. So if you use opioids and anxiolytic medications, they reduce the anxiety, and then it can also help with anxiety. Music therapy is also helpful at this point. So maybe you want to play the patient with gentle, enjoyable music, enjoyable tones that the patient wants to listen to. This will also calm the anxiety and reduce dyspnea. Now, constipation, dietary modification is most important for constipation. Fiber-rich diet, a lot of fluid, and in extreme cases, you want to try laxative. But don't forget, always start with dietary modification and fluid, because by the time you tilt the patient towards diarrhea, you're already in more problems. Don't forget, the side effect of chemotherapeutic agent is already diarrhea, and if the patient is constipated, you want to try to get the patient to move well, not to tilt the patient into fluid and electrolyte loss and diarrhea. Depression is a common symptom for patients with palliative care. Some of these patients might be quadriplegic, they might be aphasic, some of them might have bihemispheric stroke. These are patients that know that they are dying. These are the patients you want to be, you want to be sensitive around. Be careful as a clinician so that you don't throw words around. That whisper you made to the nurse when you thought the patient was sleeping could have been, something that would tilt the patient into depression. Be careful of how you talk around the patient. The attitude, your bedside attitude is going to go a long way in the quality of care you give to your patients. And depression is real in patients with palliative care, so emotional support is going to be very important. You want to invite the patients, you want to ask the patients if they need spiritual counseling. So this is the time to invite their pastors, their imams, their and whatever religion that the patient, or whatever form of spirituality the patient practice, you want to give them some spirit. You want to remind them of the option of spiritual counseling. The psychiatrist can always review and comment the patient on antidepressant medications, antidepressants. Now, incontinence is also something that you're going to deal with if you're working with palliative, with cancer patients that need palliative care. And I can tell you from clinical experience that the role of the pulse tube, right? The role of the pulse tube is kind of limited. Now, the pulse tube, for those of you that might not know, the pulse tube is not actually a urethral catheter. It's a device that you put around the phallus for male patients, and then it collects the urine, and then the urine drains into the urine bag or collection, whatever device you have down there. Contact of urine in the pulse tube with the skin of the phallus can tilt the patient into coronal excoriation, penile excoriation, and this is also a problem you want to avoid, because your patient is already on a gamut of medication. You don't want to cause any problem. You don't want any iatrogenic problems for your patient already. So I would advise that an indwelling catheter, probably a silicone indwelling catheter, will be better for your patients if they have incontinence rather than the pulse tube. Put in an indwelling catheter. If it's a silicone catheter, you change it in 12 weeks. If it's a Foley's catheter, you change it more frequently in 2 weeks rather than you change it every 2 weeks. And then if it's a silicone catheter, you change it every 12 weeks. You can also nurse your patient with a diaper, but don't forget that urine is toxic to the skin, and that can lead to perineal excoriation because of the toxicity of urine to the skin. Pressure ulcer is also something you are going to deal with if you are dealing with patients who need palliative care. So you want to be very careful. Make sure the beddings are dry. Make sure if you have the facility, nurse the patient on water beds or air beds. There should be no creases on the beddings, and try to turn the patient to if you develop bed sore, it's a positive feedback, because the patient will still have to lie on those parts of the body, worsening the sore. And in fact, in more cases than not, the sepsis from bed sore can now be the cause of death of this patient. So you have to be careful when you are nursing patients, especially patients that are not ambulant and are bedridden. So keep the beddings dry, keep the patient dry, regular turning of the patient, and when they develop bed sore, immediately and aggressively start managing those sores so that they don't develop further. Honey dressing has been found to be very effective. I did a presentation, I wrote a paper on honey wound dressing when I was a medical student, and the benefit of honey if you get pure uninfected, clean, sterile honey on wounds is amazing. So you want to consider that if you're a clinician in active care. So of course, this is WHO analgesic ladder for treating pain. This is something you should be very familiar with as a clinician. Always when you want to manage pain, the first thing you do is you clag the pain using sucrate pain. So the site, the onset, the character, radiation, aggravating and relieving factor, timing, and all that of pain. There's a video on pain management in my YouTube channel, so you can on clacking pain in my YouTube channel, so you can check that. Maybe I'll drop a link here up there. But you grade the pain 0 to 10. If 0 is no pain and 10 the patient wants to die, where is the pain? So when you scale that pain, from 1 to 3 is mild pain, from 3 to 6 is a moderate pain, and 7 and above is severe pain. So 8 and above is severe pain. Anyway, you grade the pain, and then that will guide you on the kind of analgesic you want to give. For mild pain, we use non-opioids, with or without adjuvants. Adjuvants are drugs that are not pain medication themselves, but they help the management of pain. Examples of adjuvants are nerve stabilizers like pregabalin, gabapentin, tiagabine, and the other families of peripheral nerve stabilizers. Other adjuvants can be vitamin supplements like Neurovite Forte and other supplements. So those are adjuvants to pain medication. Steroids can also be adjuvants in the management of pain, but non-opioids are NSAIDs. So your Cerebrate, non-opioid analgesic can include diclofenac, the NSAIDs, all of them, ibuprofen, diclofenac, and the gamut of other NSAIDs. Weak opioids are used for moderate pain, and now we're stepping up in the ladder. So weak opioids can include dihydrocodeine. So weak opioids can be used. I'll put a list of weak opioids here, but they can be used as with or without adjuvant. Now, if you're moving on to the ladder, don't forget that you use what you have been using before, and then you're going to add the next layer. So at this point, So at this point, we are already using weak opioid. We're already using non-opioids and then weak opioids. Then when we step up the ladder, we use the previous step plus new medications, and then this will be strong opioids here. So this is, these are details of the analgesic ladder. So weak opioids, strong opioids, stuff like methadone, stuff like morphine will be very helpful here. And most clinicians are afraid of opioids because the media and maybe our training have also colored our perspective to opioid. But these patients are already in distress. You want to ensure that they are comfortable. So opioids are not something to run away from. Tramadol, morphine, codeine, methadone, these are the time to use this. This is the medical clinical indication for this drug. So do not and be generous in your administration of this opioid. Don't hold them back. Of course, you want to be careful so that you don't see the patient into respiratory depression. But if the patient still has pain, please address the pain. The goal of palliative care is the quality of life, and key to that quality of life is what? Pain management. And pain management, opioid is your go-to when it's severe pain. And other things can be done also, like nerve block, epidural, and neolytic therapy. But these are also invasive, and you don't want to add them here at this point. But opioid, your go-to medication for palliative care pain. Alright, so other things you can do to manage pain include guided imagery. Patients have been known to benefit from acupuncture, from pets and art. Depending on the patient, the particular patient you are dealing with, music would also be helpful. Relaxation, hypnosis, if you have a clinical psychologist on ground, these can be helpful things that will guide the patient as well, that will comfort the patient. Massage, cold and heat therapy, yoga, distraction therapy can also help in pain management. Now, caregiver burden is a reality in palliative care. It's underrated, but it is very real. So I advise that you counsel the patient to provide, especially when the patient is nursed at home or coming as an outpatient to the oncology center or wherever you are doing your palliative care. Offer the patients and the relatives the option of professional nursing services so that they can help the patient and help the caregivers of the patient. Because by the time the caregivers are fatigued, they begin to ignore the patient, and then they begin to they can even be depressed from this episode. Palliative care, caring for a sick relative is a very burdensome activity, and you want to reduce this, especially on the caregivers. The challenges in palliative care are lack of training in palliative care, lack of resources. That's part of the reason why I'm doing this video. Patients' comorbidity, so you can have a diabetic, hypertensive, post-stroke patient who has now metastatic prostate cancer, has a whole gamut of things to deal with as a clinician. Lack of accountability, and since there is poor training and poor resources, people are not really held accountable in clinical practice. But this is of course this is dependent on wherever you're practicing, and this is why this video is here, so that to guide you, so that you can have the highlight of palliative care. And of course, lack of research. People don't see the reason to invest in research in palliative care, since we know the patients are dying. But life should never be seen like that. Life should always be seen from an inherently valuable state. Immediately we begin to treat life as from a pragmatic point of view, that opens us up into a rabbit hole of a lot of unethical practices. So there's still lack of research in palliative care anyway. Alright, so essential medication for palliative care. This is just to round up our discussion now. Analgesic, laxative, gastric protection, antiemetics, steroids, opioids, appetite stimulants, anxiolytics, antidepressants, antibiotics. These are all things that are should be available if you want to give quality palliative care. Now, just to round up our discussion, and this has been a long discussion now, but the top 5 regrets of the dying are people regret that they did not live their dreams, they did not really live their life, they were living for other people. People also regret that they worked so hard rather than spending time with their family. People's third regret is that they didn't have courage in expressing their feelings. People also regret not being in touch with friends and family. And then also some people regret that they have not allowed themselves to be happier. But this was a research conducted by Dr. Richard Smith, contemplating my deathbed. Is a very important thing. If you can deal with this, if you can use this to guide the patients, helping them to find meaning in their life, helping them to connect with their family, and if you can address this point why the patient at the diagnosis, not until the patient is already gasping for air, if you can address this early on in the diagnosis, it's going to help the patient, get some closure in their care. I will conclude by introducing you to this book, When Breath Becomes Air. It was written by Paul Kalanithi. It's an amazing book. It described cancer, lung cancer, from the eyes of from the perspective of a clinician. Paul Kalanithi was a neurosurgeon, an American neurosurgeon and writer, who described his lung cancer, what he experienced, both in clinical, seeing. Most clinicians have always been given care. They've never really received care. This is someone telling you how he received care and things he saw. It was a really eye-opening book for me. I'll probably do a review in my channel as well of When Breath Becomes Air. So thank you very much for watching my video to the end. Please like, subscribe to this channel. No promises. I don't promise I'm going to be doing more videos on YouTube. Because I don't want to promise and fail, but I really look forward to doing amazing content this year in 2023. Thank you for watching, and have a wonderful time.